Okay, Kiara, we'll get started. I want to thank all of you for joining us today for the inaugural presentation of Med Aditus Presents for the 2025-26 seminar series. I just want to reiterate what the main purpose of this seminar series, and that is to present interesting, timely, authoritative work on medication equity issues facing sub-Saharan Africa. Today, we are very, very fortunate to have a truly distinguished speaker to launch our seminar series. Dr. Sachiko Ozawa is an internationally recognized global health economist and associate professor at the UNC Eshelman School of Pharmacy. Her research focuses on evaluating the economic impact of vaccines and medication access with a mission to improve health outcomes in low and middle income countries through equitable, evidence-based strategies. At UNC, she leads the Global Health Economics for Pharmacy lab, where she works at the intersection of pharmacy, public health, and public policy. And so with that, I want to just thank Sashi for agreeing to present today her research, which is very much internationally recognized research relative to fraudulent and substandard medications in Africa. Sashi, we're all looking forward to your presentation today, and welcome. Thank you.
Thank you very much. Ash, are you able to share your screen, or should I try to do so?
I will do it shortly.
Great. Wonderful. Well, thank you so much for the opportunity to present today. My name is Sachiko Ozawa, and I'm an associate professor at the Eshelman School of Pharmacy. And today I'm talking to you about what we know about substandard and falsified medicines, specifically in Africa. This is going to be about a systematic pharmaceutical investigation about quality of medications. Great. So what do we know about this? There are 4 questions that I want to go through today about substandard falsified medicines. First is, how big is the problem? And then what is the impact of these substandard falsified medicines? And why is this actually happening? And what can be done about it? So hopefully we can end with some conclusion about what can be done. So I'll first focus on how big is the problem and what is the impact. So what are substandard falsified medicines? The World Health Organization has defined these, and substandard medicines are those that do not meet quality standards and specifications. And these are often due to poor manufacturing practices or inadequate quality control during the shipping and storage of these medications. Whereas falsified medicines are those that are deliberately misrepresenting their identity, composition, or source. And these are often created and distributed with an intent to deceive consumers for financial gain. So you can understand the difference between substandard medicines that may be degraded or expired or just not meeting specifications from the manufacturing process, compared to the falsified ones that have a a bad intention to actually deceive someone by creating medicines that are poor quality. So the World Health Organization found in 2017 that 1 in 10 medicines, essential medicines in low and middle income countries, were poor quality. They failed quality control tests. And so we conducted a systematic review to see if this is really true among all the different papers that have been published that conducted a chemical testing analysis of medications. And we see here that the prevalence is right around that amount. So overall, we found that it was around 13.6% of all the medications that were tested in low and middle income countries failing to meet quality control standards. And in Africa, this was actually higher. It was highest among all the different continents that we were looking at 18.7%. The majority of medications that are tested and reported and published in these publications are around antimalarials and antibiotics. And that's because a lot of global health funders were actually testing the quality of a lot of those medications and actually reporting them. It doesn't mean that we don't have poor quality medications for other types of medicines. These are the ones that were tested the most. And if we go to the next slide, we see that the medicine quality is really a global problem, that it's not just going to be in one continent, that it's kind of spread throughout, and that there's a big chunk that is going to be happening in Africa. And I'll tell you a little bit more about why in Africa in particular, we might have more of a problem around medicine quality. Next slide. We also wanted to understand a little bit more about what are we talking about in terms of substandard versus falsified medicines. I told you earlier that substandard medicines are those that are not meeting quality standards, and then falsified ones that are intentionally made to do so. We conducted a study another systematic review to try to understand what proportion of the medicines are actually really bad, with less than 50% of the active pharmaceutical ingredient. And we found that that's around 1 in 7 of the failed samples, whereas 6 of the 7 failed samples are likely to be substandard. So the majority of the problem is actually more on the substandard medicines rather than the falsified medicines, even though you might think, that counterfeit medicines or those that are fake, falsified, are those that will catch the news the most. It's important to understand that a big part of this problem are those that are not going to be in the news all the time, that they may be substandard and maybe, not created for ill intent, but they're still going to not be meeting the quality standards that would help patients get better. Now, what's the impact of these substandard falsified medicines? It's really easy to think about just the health impact, right? In terms of the medications not working, you might not get better, you might be sick for longer periods of time. There may be other things, even within health, like loss of confidence in medications, loss of trust in providers, and also around progression of antimicrobial resistance, especially for many of those antibiotics that are substandard and falsified. It may contribute to building resistance. There's also socioeconomic and economic impact with these substandard falsified medicines, and that might be lost productivity, lost income, even lack of social mobility and increased poverty because you're spending a lot of money on medications that may not be effective. There could be greater economic loss to the country and wasted resources, as well as increased out-of-pocket spending that might be putting a lot of patients at harm. So what does this look like in terms of the evidence that we have in the literature? So the impact of substandard falsified antibiotics and antimalarials have been studied. We've also published a number of papers around this. This was the seminal one from the World Health Organization that stated that nearly 72 to 170,000 excess deaths are attributable to poor quality antibiotics to treat childhood pneumonia yearly. And between 4 to 9% of malaria deaths are related to cases seeking treatment in sub-Saharan Africa due to poor quality antimalarials. What else do we know about the impact of poor quality medications? We've conducted some studies recently about the impact of substandard uretonics. And we conducted these in 3 countries, Ghana, Senegal, and Nigeria, and have recently published them if you'd like to take a look at these in more detail. So uretonics are medications that are really important for maternal health. They save mothers' lives and prevent postpartum hemorrhage, which is a leading cause of maternal death. So in the next slide, I show you what this actually looks like in terms of our analyses that we've conducted. across those 3 countries. And we found that improving the quality of uterotonics in these countries could really improve the number of maternal deaths that could be averted, as well as postpartum hemorrhage cases that could be averted, as well as the costs that could be averted. And these are costs that both individuals are spending to get to the facilities and seek treatment and losing productivity, as well as the amount that the facilities, the governments are actually paying for poor quality uterotonics. And we found that improvement in uterotonic quality could annually save over $89 million in Nigeria, $18 million in Ghana, and $1.3 million in Senegal, leading to 100,000 fewer postpartum hemorrhage cases per year overall. And as you can imagine, these could accumulate a lot if you think about compounding this over many years. This is a huge problem that could be averted by improving the quality of medications. Another study we conducted recently is around anti-cancer medicines. So we wanted to understand what the impact of substandard anti-cancer medicines are in countries in sub-Saharan Africa. And we conducted this in 4 countries, in Cameroon, Ethiopia, Kenya, and Malawi. And we found that 1 in 6 anti-cancer medicines that we looked at failed quality control tests among all the different samples that we collected. And we collected samples both in the public sector, through those that are sold through the central medical store, at different hospitals that are treating cancer patients, as well as at the private pharmacies where people may have to go to if the central medical stores and the main public facilities are stocked out. And we found overall, across all the different medicines, that we were finding these failed samples. So why is that a huge problem? Because people are actually spending a fortune on these anti-cancer medications as well, right? So this is a figure in a paper that's about to come out on the chemotherapy medication costs in terms of days of government worker salaries for 3 different common cancers by country and facility. And across those 4 countries, we were finding that, in order to get treatment for these anti-cancer medicines, people were spending hundreds of days of government worker salaries in order to access them. So imagine spending that much money for treatment that is actually not going to work. That could be a huge burden, not just to the families and the patient, but also to the government as well. So now that I told you a little bit about the problem and the impact that this problem has, let's talk about why is this happening and what can be done about it. So remember, I showed you a little bit about, with a map earlier about, where we were finding substandard falsified medicines. Now, the global manufacturing of medicines have gotten so complicated that the medicines that you might find in a store, a pharmacy, or a public clinic in Africa may actually come from all the different countries above, right? So it may be the central medical store in a country is buying from a wholesaler in a different country that is being imported and from a manufacturer in a different country that is actually receiving both the active ingredients and the excipients from another country. So there's a global journey of medicines that's important to remember because these manufacturers, the wholesalers, all the different entities here may actually be regulated differently. And there may be lots of different loopholes that is actually happening within the supply chain, resulting in substandard and falsified medicines. So how can the regular legitimate supply chain of medical products be compromised? So and this is more around the falsified medicines, if there's a criminal intent of any of these entities, then these are different ways in which the medical products can be compromised. So at the manufacturer level, the manufacturer could actually create falsified medical products. They can export medical products without respecting the export laws and regulations. Wholesalers, there are a number of different wholesalers that are typically involved that could import unauthorized medical products to countries, distribute them through unauthorized channels, such as through the gray markets, or you can actually steal them from warehouses and then move them to different channels of distribution. Right? Also, at the pharmacy, hospital, and clinic level, there may be some bribery of health officials to sell the medical products in bulk without a prescription. There could also be distribution of these falsified medical products through pharmacies, hospitals, and clinics. So these are the different ways in which there may be compromises happening within the legitimate supply chain from criminal actors. So how would you actually regulate something like that? There are huge regulatory gaps within Africa. And this might be the reason why we have a lot of substandard falsified medicines, especially in Africa. So only 8 of the 54 countries in Africa have African national regulatory authorities that operate at a maturity level 3 of the WHO global benchmarking tool. Now, what does that mean? That means that the regulatory authority is stable and well-functioning, and that's just 15% of all the countries that have met this specific benchmark. And you see here the list of countries. Ethiopia and Kenya are currently under evaluation, so hopefully there'll be more countries that will be joining this higher level maturity. But we have a lot of national regulatory authorities that do not have the capability to be able to regulate medicine quality. Also, the African Union model law uptake remains slow, and less than 12 member states have completed or formally initiated domestication. What does that mean? That means that in many African countries, there isn't a model law for making substandard or falsified medicine distribution or sale a crime. And the sanctions are also very weak. So in Tanzania, for example, the legal maximum fine for falsified medicine offense is only around $2,000 or 3 years in jail. You can imagine if there's some criminal intent, how much money you might actually be able to make from selling those falsified medicines compared to these sanctions. The United Nations Office on Drug and Crime reports that fines are typically below $36,000, even when seizures exceed over $1 million in value. So you can see the discrepancy between the amount that the criminals could make versus the sanctions. Now, we talked a lot about the falsified medicines, but there's also substandard medicines, right? And there's a lot of quality control gaps as well within Africa. So across those 54 African countries, there's only 9 WHO qualified national medicines quality control laboratories. So imagine we have lots of countries with only 9 labs that could actually test medicine quality legitimately. And then the national regulatory authorities have a small budget, and they tend to be highly donor dependent. So when donors are not giving as much money, then they struggle in actually testing the quality of medicines. Post-market surveillance is limited, and so that's one of the activities that these national regulatory authorities conduct, to actually go and test the quality and do some selection of medicines and then to test the quality of those medicines. And in Nigeria, for example, in 2022, they report that they were only able to test around less than 5% of the medical products that they have in the country. So you see that, surveillance is limited, and there's also fragmented alerting going on, where recalls are not always plugged into the WHO global surveillance and monitoring system. So even when there's a recall of a product, it may be difficult to make sure that those recalls are actually shared with surrounding countries, because oftentimes if there's a substandard falsified medicine that appears in one country, it's highly likely that it's also appearing in a surrounding country. So I wanted to bring this up because especially for uterotonics, it may be that they're not necessarily falsified, but more substandard. And it may be that certain medicines are not as stable. For example, these uterotonics are sensitive to high temperature or light or humidity. And this could be a problem both in manufacturing, but also in storage conditions during transport or distribution. So when medications are not stored appropriately, when they're not kept in the right temperatures and humidity, they can degrade. And that might also be happening here in the amount of substandard medicines that are found in sub-Saharan Africa, where, for example, uterotonics are recommended to be in the cold chain, but they're not always in a cold chain in many of these countries. So you see on the right figure of the amount of different uterotonic medications that are failing to meet the quality standards. So what do we do? The World Health Organization has this strategy called the Prevention, Detection, and Response, a PDR. And this focuses on three main things: ensuring access to quality medical products, because if you're able to improve access, then people don't actually have to go to gray markets to get poor quality products. Another is building regulatory technical capacity, and that is both for the prevention as well as the detection. It's really important for these regulatory authorities to have the capacity and the resources to be able to detect and prevent medication that are substandard falsified. And also to provide convincing evidence of good governance. A lot of this is also about governance and having good border control alerts and recalls. And so the World Health Organization is working hard to work with countries to make sure that they have stronger national regulatory authorities who could combat substandard falsified medicines. Now, since we're on the topic of Africa, I wanted to bring up what the African Union is actually trying to do. So there was a meeting about a year ago in August 2024, where the African Union specifically talked about the concern that they have around substandard and falsified medical products in Africa and how that is a huge threat to the public health and the economic loss within the continent. And they wanted to change the approach they've been taking around this by establishing a working group on substandard and falsified medicines and really focusing the working group to think about what the African Union could do. So in the next slide, the working group was launched and put together by the African Union Development Agency, New Partnership for African Development. And this African working group on substandard falsified medicines met in Addis Ababa in July this year with 18 voting members, representing all sorts of different folks from national regulatory authorities, customs, academia, judiciary, law enforcement, and procurement agencies, and then also having these non-voting observers from all the different agencies that are interested in helping to improve the quality of medications in Africa. And I was able to sit as a voting member of this committee to contribute to the knowledge around substandard falsified medicines in Africa. So here's our working group. And we have 4 sub-working groups, one on data and research, one on technology, one looking at the convention, the laws, and the governance, and lastly on communication and advocacy. And this will be a working group that will stand for a while. I think we have at least a 3-year mandate now as part of our current members to continue to work toward generating evidence and improving visibility around the importance of substandard falsified medicines, especially in the African continent. So here are the key actions that this working committee is trying to take. We're trying to develop a continental plan on substandard falsified medical products, including a health and criminal justice response. facilitating the nomination of a African Union champion on the elimination of substandard falsified medical products, so we can have more of a political push there as well. Also developing and implementing an African Common Policy Framework on pre-shipment screening of medical products, and then facilitating member states and countries on this pre-shipment screening so that that could be conducted. And finally, supporting African Union member states on domestic manufacturing of medical products, as well as pooled procurement mechanisms of these medical products with insurance about quality. And this is really important because improving the quality of medical products and a lot of it also has to do with the cost and making sure that there's access, right, of affordable medical products that are of high quality, hopefully through domestic manufacturing and also through pooled procurement, which could actually reduce down the costs by procuring together across countries in the continent. One more thing I wanted to note was as part of the Med Aditus Foundation's webinar today, the foundation is also working toward combating substandard or falsified medicines. The mission is to enable medication access equity in Africa through education and training, technology, advocacy, regulatory reform, and leadership development. And as you see on the right, one of the strategic priorities is to combat substandard drugs and fight the spread of substandard or falsified medicines, as well as other priorities here. And I think it's really great that the foundation is supporting a webinar like this and can spread the word about the importance of this topic and how we could work together to improve medicine quality. Finally, I'm going to conclude with why medicine quality matters. So ensuring good quality medicines would improve health outcomes and result in cost savings for governments and families. But it also can contribute toward countries achieving universal health coverage. Why is that? Because if countries could actually improve medicine quality, that means that they're not going to be spending as much on medicines that are poor quality right now. And people will also not have to be spending on medicines that are not good quality and may also get better faster, right? And may have less treatment needs that are a result of substandard or falsified medicines. So we think it's really important to realize that this is not just a health problem, but also an economic problem. And finally, this is a lovely system map that we created that links medicine quality with universal health coverage. I wanted to share this with you. Sorry, I'm an academic, because I think it's really helpful to kind of see all the different linkages that's happening between medicine quality and the other broader benefits to society. The blue circles in the middle, that's the medicine supply chain mechanism that we've laid out all the way from manufacturing to patients being able to utilize medicines. And then the yellow bars, those are yellow boxes, I guess. Those are the interventions. Those are the different ways in which we can actually improve the quality of medicines. And they may be things like regulations and oversight and recalls and good practices and things like that. And then we have two boxes to the right. The bottom right box is showing the impact of quality medicines. And these have things that are like benefits to the beneficiaries, as well as the mechanisms in which these people may benefit from better quality medicines. And then toward the right, upper right, you have a huge box there on the universal health coverage. And this is the linkage from the medicine quality to the universal health coverage, where if you're able to save more money by improving the quality of medicines because you're not spending as much on additional needed healthcare or treatments that fail and you need to be bought again, or people are in health facilities for longer periods of time, then those cost savings could actually be invested into universal health coverage so that people can actually be covered more by insurance, or have more medication access, or have to pay less out of pocket for medications. So that's the end of my presentations. Thank you very much, and I'm happy to take any questions that you have.
Thank you, Sashi, for a great presentation. And so we want to open it up to the floor for questions that anyone might have. Well, maybe while people are thinking, Sashi, I'll offer up an introductory question. You talked quite a bit about what can be done, and you mentioned that the African Union is trying to lead a coordinated effort, and bringing all the countries together and perhaps acquiring a common standard. Are there exemplary countries that you feel have gotten ahead of this, that could serve as role models, for other countries?
That's a great question. So the 8 countries that currently have the higher level of the National Regulatory Authority maturity level, those are the countries that have much stronger regulations in place, as well as technical capacity. And many of those countries are the kind of the leading force within Africa, especially when it comes to medicine quality. Now, recently, just a couple weeks ago, I believe South Africa had the national action plan for substandard falsified medicines that just launched. So there may be something there to also look at in terms of how that country's looking at tackling substandard falsified medicines now, and the literature and all the different resources that they're using to support the case, as well as what the political actions they're hoping to make.
Yeah. Thank you, Sashi. One point that I also wanted to make, and probably should have made this on the front end of the presentation, and that is when the founder of Med Aditus got started in all of this, it was really on the basis of an observation that he made regarding falsified and substandard medications, with regards to establishing Med Aditus International, which later became Med Aditus Pharmaceuticals and Pharmaceuticals Kenya. And Darren, I think that the story that you tell, about how you got so your aha moment was the observation of maternal health, and the very example that Sashi gave, in her presentation, as being one of the most damaging and detrimental to the health and well-being of mothers, postpartum. I was wondering, maybe it would be interesting for the audience today to just hear a little bit of that story. You're on mute, Darren.
Yeah. Yeah. Thanks, Bob. Bob has heard me talk about this a lot. This was in 2013, 2014, 2015, that time frame. Our School of Pharmacy had developed a partnership with Monash University's Faculty of Pharmacy and Pharmaceutical Sciences and University College London School of Pharmacy. And we had, as this international partnership, we had agreed that we should look at sort of a global challenges that the world faces in the area of pharmaceutical sciences. Besides just interacting with each other and having research collaborations, we felt like as 3 leading schools in 3 continents, when we come together, we should be thinking about much bigger problems that exist. And that led to some systematic sort of review of, both access to medicine in different parts of the world, but also at that time we called it, just in a very colloquial language, counterfeit medicines. And I think when we looked at this, including specific, some of the research that Sachi, you have presented today, we looked at some of the papers, but we also looked at anecdotes and a number of different ways. And I guess the one that moved me the most, although any substandard medicine or any falsified medicine has a devastating effect on patients. I think in many cases I see that it's worse than not having medicine, because they are under false sense of security that they are taking medicine and trying to alleviate or cure diseases, and they're not. They're in a complete dark. And among those stories was the one that you mentioned, Sachi, and that is oxytocin. That was, I think the story that we had, certainly I heard, was not substandard, but actually falsified. And leading to, and as you pointed out, it's can you imagine a mother who has just given birth to a child, takes oxytocin to stop bleeding, and nothing happens, and she bleeds to death. And instantaneously, you are not only, it's not just her life that is ended, but a newborn child is now without a mother. I think that really touched me to a point where I said, I cannot just listen to this. And certainly we are working on this at the institutional level, but I made a personal decision that at some point soon, I will leave my academic position and work on this problem full-time. So that was sort of a genesis of the decision to that ultimately led to launch of the nonprofit Med Aditus International, and entire I guess focus of this initiative is to how do we improve both access to medicine in areas where access is a problem, and more importantly, also, how do we focus on the quality of medicine and affordability of medicines? So I think that is certainly, I think the type of work that you have presented certainly was instrumental in my decision to start all this. And I hope that I think we are making progress, and I don't think we will stop until we actually put high quality medicines in the hands of patients. And I hope that we can use that to then spread this whole idea of developing local capacity, which reduces certainly cuts down on the length of the supply chain that you so aptly showed, and thereby and of course with other improvements in the government policies and oversight. The goal is to really, we have to do this. We can't just watch this happen and keep citing statistics. So
Thank you, Darren. I've got a couple other questions. Rebecca, Emily, and Nazim. So Rebecca?
Yeah, great. Well, thank you very much. And first, I just want to say hi to everybody. And certainly with Darren, I know that I remember him talking in his early days about this vision. So it's amazing so many years later coming to fruition. But that was my earlier life. And my current life, I've been leading a project called Safe, Affordable, and Accessible Medicines in Ukraine. So obviously this topic is very near and dear to my heart. And Sachi, those slides that you presented, even though my focus is Ukraine, not Sub-Saharan Africa right now. Ukraine is a middle-income country and suffers many of the same challenges that many countries in Africa do in terms of substandard, especially, but even falsified medicines. And one of the streams that we work in is addressing substandard medicines. And in Ukraine, we have been working. I actually do have a question, not just sharing my experience. In Ukraine, we're doing two streams. We're addressing equality. One stream has been helping the government strengthen its regulatory environment and create. They've had regulatory functions, but they've been not very strong, very high risk of special interests because there's big pharmaceutical companies in the manufacturing in Ukraine that have been manufacturing medicines that haven't really checked out quality-wise for many years. So we've been helping strengthen that to be more aligned with the European Union. But the second area of kind of interest here relates to a question I have about, I know you mentioned in one of your slides, the use of technology. And in the Ukraine context, we've helped the country successfully start the process of a legal framework for a national serialization system, which is, at least in terms of the European context, one of the ways to ensure that medicines from manufacturing all the way to pharmacy and to the doorstep is tracked using 2D coding. And the manufacturers come together and agree to these principles, and all packages are coded. So my question is whether or not these track and trace systems are existing anywhere in the African continent, and what the likelihood is of them in the future, and if you're studying any of these track and trace systems.
Great. Thank you very much for that question, Rebecca, about track and trace systems. Yes, they do exist, and I think they're being more and more implemented in different countries. GS1 is a standard around kind of barcoding that has been adopted, and they're presenting everywhere around these substandard falsified medicines conferences about all the different ways in which they're trying to attract different countries to adopt the system and doing different pilots in different countries. So I believe that there are more and more of these technologies that are trying to be implemented. There's also different chemical testing toolkits that have been adopted. So the mini lab is one of those that have been more widely adapted across Africa because they're less, cheaper kits that could actually do some of the testing of quality. They still require some technical training of different individuals to utilize them, and it also requires you to have reagents as well as maybe some standards to test the quality against. And so that's where a lot of the cost and issues come up with regards to countries actually continuing to utilize them. There's also screening technologies that we actually did some cost effectiveness study in Kenya, looking at how much it would cost to utilize different screening technologies. Many of them would always be cheaper than actually continuing to utilize like full-blown HPLC analysis to test the quality of medications. And the problem with doing the full-blown testing is it takes forever. It takes so long that by the time you know that there's a poor quality product that has been sitting in the pharmacy shelves for a long time and being continued to be utilized. And so I think the timing is an issue. And I know there's also some of those screening technologies that are used at the customs and borders, as well as all the different regulatory authorities are continuing to try to use them. But there's funding issues, there's sustainability issues, and technical training issues as well that continue to thwart better, stronger regulatory systems in many of these countries.
Thank you, Rebecca. And Rebecca, you probably have given us a good topic for a future Med Aditus Presents. Tracing and tracking is an important part of the work that's going to be done and performed by Med Aditus in the future, and also incorporating blockchain technologies as an additional component to that. And we'll save that for another topic because that could be a very extensive conversation that we could have. So thank you for that question. Emily, and then Nazim.
Okay, sorry. Can you hear me?
Yes. Yep.
Okay, great. Thank you so much, Sachi, for a really fascinating presentation. This is really, really interesting and complex. And as someone who's worked in the maternal health space, I was shocked to hear the statistics around uterotonics. And frankly, that's not a conversation I've heard in conversations around maternal health and the service provision for maternal and infant health. So my question is, in your opinion, what's the role, and maybe you can speak to efforts that are already happening, what's the role for advocacy from patient advocates or from community members? You see a lot of work in that space in HIV service provision about ensuring access to medications. Of course, there's a huge conversation around universal health coverage. And to me, this is really such a complicated problem that needs to be addressed from so many different aspects, training and regulation and imports and laws and legal aspects. I wonder if you had any thoughts to share about how advocacy from patients, communities, healthcare providers, pharmacists, how that can play a role in this question, especially regards to maternal health, because that's such a shocking example.
Yeah, thank you so much, Emily. I think we undertook these case studies because this hasn't been raised before and because we knew that this could be a problem. And as more countries were starting to test the quality of uretonics, it became clear that this is a huge problem. And that's why a lot of our papers are very recent. They were coming out last year and this year. And so I think there's more advocacy needed now to raise this issue and to really bring this to people's attention. There was also another study in Nigeria that actually found that doctors were giving 4 times the amount of oxytocin because the medications just weren't working. And you can just imagine what the adverse events, effects would be of giving that much oxytocin. Even though the active ingredient may not be there, there's other things in the medications that could also be causing harm. And the amount that countries are spending on these medications that are not good quality. I think it's really important to raise awareness, and I strongly agree with the need for advocacy. I think it's really difficult for things like uretonics, which are old medications that are paid by the governments, and nobody's really advocating for those medications anymore. Pharmaceutical companies aren't making much money out of those oxytocins. And now it's all in the generic market. So it's the people who are utilizing it, who are finding it to be poor quality, who really need to, show that, hey, this is really a problem. We need to actually do something about it, and kind of, raise awareness bottom up.
Thank you, Emily, for that question. Nazim?
Thanks, Bob. Thank you, Professor Ozawa, for a wonderful sort of summary of this very significant problem, particularly in Sub-Saharan Africa, which is very close to my heart because I'm one of those guys who actually ran a facility for 20 years in East Africa and have numerous examples of coming across substandard products. And the one that comes to mind immediately is we realized one day that in Kampala, there was a pharmacy selling ibuprofen at a cost lower than my API cost of ibuprofen, so, which is not uncommon, sadly. So we actually did some analysis and realized that it failed a lot, failed dissolution and various other tests. We took the sample back to the NDA. By the time they asked for a recall, of course, it had all been used, right? And this is just one of many, many examples. 2 issues that I've had, and they're sensitive, but I don't know how to address them, but I'm sure you do. One is that a lot of these are actually coming from India and China, a lot of them. And there are many examples of, particularly if you talk to my colleagues in the NDA in Uganda, they'll give you those examples. So what do we do there? How do we, what mechanisms do we put in place to stop that? And secondly, which is even more sensitive, and I'm sure you're very aware of it, is that a lot of middlemen are making money out of this, right? And a lot of those are pharmacies, well-known, linked to the government. So how do you handle that? And I think since you're part of the working group with Ayuda and NAPAD, maybe those are issues that you might wish to raise. I'd love to hear your comments on that. Thank you.
Yeah, great comment. Thank you so much. I think you're alluding to the global nature of this problem, from the manufacturers in India and China all the way to Africa. The Bottle of Lies is a typical, good example, a book on how those medicines in India come to Africa at a different quality standard than they do to America, for example, right? Because there are looser regulatory systems in place in Africa, that they are receiving these poor quality medications that may not have passed the regulatory control in higher income countries. So I think one of the main things that the African Union is really looking at is strengthening those regulatory technical capacity as well as the laws. The laws have to be in place first to even catch the criminals. And in many of these countries, having substandard medicines is not a crime, and that's a problem. So I think that's where we're starting, and I'm hoping that there'll be more cases that are also brought to the African medical authorities around substandard falsifieds that would medicines that would improve visibility around the topic and kind of more advocacy, as we were mentioning earlier. That could also help the African Union as a continent negotiate or work with India and China and all these other entities that may not be controlling their exports as much. So this is a global international problem that where lots of different international organizations are actually needed to help improve the quality of medicines and across the world, but especially also in Africa.
Thanks, Nazim, for a really fantastic question. We might have time for one very quick question if anyone has a final question they'd like to ask Sashi.
I have a quick question. This is Adam Shahan talking. I'm a recent graduate from UNC Eshelman School of Pharmacy, and I also interned at Med Aditus for quite a bit. So I'm really glad to be here today. And I'm sorry if this is a very silly question, but I'm honestly, this has just come up because out of curiosity, when thinking about like the different sub-Saharan African countries, some of them are dealing with a lot of financial crisis in general. So sometimes it's hard for them to prioritize healthcare or make it the core of what needs to be on their agenda. And this is me speaking very broadly. So, if we know that finances is always at the core of decision making, and this, Sashi, this is for you to understand. Do you think it's possible to create a system where they understand that if they stop falsified drugs and substandard drugs from coming into their countries, or creating a system where they're making money by putting in place a punitive system to those folks who are bringing in those falsified drugs? Does that make sense? For example, like in the United States, we have the FDA, we have this very, strict regulatory system in place. And unfortunately, the FDA is making a lot of money. When you think about pharmaceutical companies, they have to pay billions of dollars to even get a drug approved. That's even if the drug gets approved. So I hope my question makes a little bit of sense.
Yeah, thank you so much. I think you're raising a really important point in two fronts. One is the importance of continuing to document like the economic benefit of quality medications, right? Of improving the quality of medications, that you're actually saving money for additional treatments and you're not spending money on things that are not going to work. So that's one of the things that we're trying to do to continue to document those in different medications, and that should help with advocacy efforts. The other point is around kind of how this could, how it's important to make sure that there's evidence for regulatory authorities to actually continue to be funded. So you just noted that there's very little money spent on health, health overall, right? A lot of that money would actually go to the Ministry of Health, and maybe a little bit would go to regulatory authorities. The regulatory authorities have a really hard time justifying the return on investment of their activities. And so one of the things that we're working on with the World Health Organization is documenting what the return on investment of post-market surveillance is, so that the regulatory authority could get enough money to control, to survey the quality of medicines, so that the medicine, so that there'll be more, counteracting force against the criminals that are trying to introduce falsified medicines into the market. So I think in many of these ways, we need to continue to have economic evidence that show the benefit of quality medicines and the benefit of improving and strengthening those regulatory systems, so that there'll be fewer substandard falsified medicines in the market.
Thank you, Sashi, and thank you, Ashia, for that question. I want to take this opportunity, Sashi, to thank you very much for your great presentation and great answer to some really interesting questions. And I do just want to give everybody a reminder. Our next Med Aditus Presents presentation will be on December the 10th. 2025, and it will be Dr. Brian Southwell, and he's going to speak on misinformation as a misunderstood challenge, implications on medication management in Africa. And so Brian is also a world-renowned expert on misinformation, particularly as it relates to medication use. And this is also an important priority for our organization as we try to address the many aspects of medication inequity in Africa. So with that, I want to thank all of you for taking the time to participate in today's presentation. Sashi, thank you again, and look forward to seeing you all next time. Thank you.